I was just wondering, from my own experience and things I hear, and I'm curious what other families have experienced who've gone through relapse. When you find your home caregiver, your home doctor, you don't know anything and everything's coming at you through a fire hose. You obviously place all your trust in the outcome of the survival, and you just go along for the ride because that's all you can do. And that trust takes place over the whole extended process of treatment and everything else. And the thing that I discovered, and I was very fortunate that your child's disease didn't explode through the relapse section, was it took me quite some time after relapse as a patient to understand what that meant, treatment-wise, option-wise, and how it was being handled as a parent asking about options. And for me, that's the one area that I think there could be a lot of improvement on, is having an understanding. Now, you don't want to sit down, you hear about the statistics, but you still don't want to believe it. But what I didn't understand at that point was that each center doesn't specialize in relapse. Each center won't necessarily talk about other specialists and other areas to go, and kind of communicate to you that you're in a different path, because everyone always told you up until that point what to do. And then that path is no longer there. It wasn't clear. But it took me quite some time to actually figure out that I was walking on this kind of road alone in terms of looking for new options. And I'm curious if other people kind of found and experienced that. And it seems to be kind of a recurrent theme. And I was hesitant at first, not even aware that leaving my home institute was an option, and that I could actually leave and come back and it'd still be there. It wouldn't, be a judgment on me. And so that was a learning process that I was fortunate that in that time frame, my son's disease didn't explode, and I had the time to actually learn that lesson. But I learned it on my own, and that's one area that I really feel can do a better job communicating. I don't think I'm alone in that experience. I'm just curious what your thoughts on that.
So our institution was not a phase 1 institution until Dr. Scholler came here 2 years ago. Right? Almost. It's gone by fast. So prior to that, regardless of the disease, but if patients relapse, we or I discuss options for what we have available here. Many times, even currently, patients and families will want to know, well, what options are out there elsewhere? And I think that can mean parents take their child and go elsewhere and talk about those options. Not all families can do that. Not all families have the means to do that. It takes time to gather those means to do that. So very commonly, I would say every month, I'm emailing or calling physicians elsewhere, particularly even tumors more rare than neuroblastoma, to get 10 opinions, which is fairly easily done. And I see that as the job of the primary oncologist to say, here's the scenario, I have this kiddo. You can even do it in a completely HIPAA private way to describe this scenario and ask about opinions or treatment options. And then I see that as the primary oncologist's role to say, I can help you with that, or if you want to go. And so I think having a supportive dialogue, an open dialogue with your oncologist about if you want other opinions, about do you need to go for those, or can your oncologist help solicit those? And what phase 1 or 2 trials are available. I also want to have respect for those families who don't want phase 1 or 2 trials. They want what you can do creatively at your own institution. I think there's great benefit for trials, because that's how we're going to learn and how we're going to change directions. But there are times that I believe it's absolutely appropriate to be innovative at your own institution with the own patient. And as long as parents understand, risks of that and the lack of proof of that, and that you're not being reckless, with agents. I think there are times in relapse settings that it's appropriate to be innovative.
I think it's just unique here because it's a great care team. I think a lot of people have different
I was going to say Dr. Mitchell is an incredible physician, and her approach is not what you're going to find in a lot of places. And I love Dr. Mitchell because of that, and all of her patients love her because of that. But there are many oncologists that don't have, many just overwork, don't have the time. They're seeing patients clinic, and to be able to reach out to 10 other hospitals and get second opinions and then coordinate all that for their patients. I think the entire parent community should say that's the oncologist's job. And I would agree with Deanna. I mean, we send patients in multiple different directions. If that's what's best for them, we need to get them where they need to go. But trying to make that happen is going to be a little bit of a culture change in some places. Yeah.
Is there somebody else that could fall back on, or is there some way to push like our local hospital? Because our local hospital was not like that. I felt like we were flying by this like every day. It was like a surprise.
Yeah.
And it wasn't. There was no forward plan. When Ezra relapsed, he did progress fast, and nobody, our oncologist, hadn't even thought of anything.
We were
He
literally
didn't know anybody.
we literally moved from very much. You go first.
Yeah. To speak to your point, Mr. Lacey, when you first start, even the oncologists, they have a protocol. They're like, okay, stage whatever neuroblastoma, we're gonna do this, this, and this. But once you get to the point with the relapse, there's no like protocol in place. But I think that would be helpful to say, okay, if you relapse at this point or with this stage of disease, then a recommendation, or not even a recommendation, but these are the choices, because it falls back on us to, at that point, to learn about the trials, to try to figure out the drugs, to even figure out to try to figure out if we're even qualified for the studies.
Even having your expectations set the correct way, so you understand that's now the landscape. That there is no longer a roadmap that is accepted and followed by everyone.
Yeah, there's no road. I mean, I think it would be helpful to say, okay, let's as the NMRTC or the COG or the NAN or whatever, say, okay, why don't we put some type of protocol in place that says, okay, let's put all the studies in the same place. I know the clinical development, I mean, that is impossible to try to figure out, unless you're a doctor, or unless you're a researcher.
Clinical.gov is a good resource if you type in neuroblastoma in the search term.
Oh yeah, but even when you pull that up, there's like 300 things, and there's like there may be the same things, and you have to figure out if it's the hospital, and you have to figure out if you even qualified for that. But it's like, they focus so much. Create the initial protocol. Why don't they try to focus on like the next protocol? Because if we know neuroblastoma is going to come back, in most cases it does come back, then why can't we have a secondary protocol that says, okay, this failed, now here's the options, here's the open, okay, that doesn't work, but some kind of way to...
Well, and the reason is that because it simply isn't known. I think to underscore Pat's point, I don't know if we necessarily realized the significance of the shift when it went to relapse, where the doctor had been telling us what the next steps were, and it literally, when he relapsed, our doctor basically asked us, what do you want to do?
Right.
And I didn't understand at that moment the fact that my assumption was that he was going to tell me the 3 or 4 things, that it was an A, B, C, or D, fill in the blank. And I did not realize that he had no idea. They listed a couple trials that they were aware of, but I assumed that my physician, our doctor that was helping us with the team, and this was naive of me, but I assumed that they knew all of the relapse neuroblastoma options, all of the trials going on, not just in the U.S., but in the world. I don't know why I assumed this, but I just did because they had always had the answers.
And other kids
they've always had these answers. So
you would think.
So I think that the point of that, and where my rambling should go, is that from the beginning in neuroblastoma diagnoses, parents have to be constantly aware of what are the options at relapse, because it's very nice that you're looking at 10 other people, but like Giselle said, a lot of doctors simply aren't, and we don't know that we need to tell you to do that, or even that you're going to ask the right people or what. And I think a lot of, like even with the Pt2.org and some of these online resources that exist, that we can get verified information now, and it's easier to search. And even 4 years ago when Ezra relapsed, that wasn't available. And so I just think for a neuroblastoma parent, it's important to be aware of that from the get-go, and you hope it never happens.
To ask your doctor, can we work it together as a team?
Yeah.
Can you consult the NMTRC, the NANT, Sloan Kettering, CHOP, Baylor? Those are probably the biggest of the neuroblastoma centers.
Bring up NCI.gov, the neuroblastoma, and say,
bring it to your doctor. Say,
what do you think?
What do you think of these?
But you're still misspelling neuroblastoma at that point yourself. You don't even know.
Change the name, it's hard to type.
I think it's okay to ask your doctor to be the detective for you. Can you find out where are the top places that do
But
relapse
you want to take
neuroblastoma?
your kid there. You don't want to have them say, okay, I'm going to talk to so and so at CHOP or so and so at Sloan. What we did is, okay, why are we talking to you? We're going there. You know what
Which
I mean?
is absolutely fine.
But
Absolutely.
you can't. Yeah. In
You know
our
what?
case, we couldn't.
Because we
and
had all
so-
we had Roswell. We thought they took care of neuroblastoma. They had 100 cases. We didn't know our daughter was the second in like 10 years.
Right.
So we trusted everything they said. And then when she relapsed, we're like, well, don't you know what to do? She's like, we're going to contact so-and-so here and so-and-so here. And I'm like, well, why are we doing that? Let's just pack our daughter up, take all her information, and go there.
And to Robin's point, though, I mean, we had another kid in the hospital. She was pregnant. We couldn't do that. We couldn't simply go and leave. So we did need to rely on some of that communication, because we couldn't leave.
I think having that bond and having a physician that you can really openly talk to and
That
relate to it.
it's
The relationship,
gonna-
especially at
yeah.
relapse, is
Yeah.
critical and very important.
It is, I think, because like what Pat was saying, from diagnosis to relapse, it's a burden shift. There were always a clear set of instructions, and it's like our roadmap didn't get us where we wanted to go, but now there's not another roadmap.
I guess my initial point was simply that I wish that there was some sort of transition meeting where there was a conversation that took place as part of the process, where it's, you're no longer here, this is where we're at. And there's just an acknowledgement of that transformation, so that you could then, if you chose to, make those educated choices about other options, while still just fully trusting your own doctor. But that felt to me, and it's something I feel like I see a lot, is that you nailed it perfectly. I felt that same assumption, that they knew all these things. It only took me till I was bringing research papers in, and my doctor said to me, I don't know any of these things, this is not what we do. And it finally clicked, and I thought that could be something very important to allow people to get into trials that are just first relapse. You can only qualify for in a certain time frame, and you don't realize it too late. So I was just curious if that's on an institutional side of not just this hospital, as everyone raves about the clinic here and how great everything is, but it's an institutional process. That's something that that maybe doctors take for granted, that we understand, we simply don't. We're not going to solve this today.
And I think the openness and communication of is there a way to have all the different options available? The different options are changing. There's new studies opening constantly, so it's a difficult database to keep track of. But I mean that's definitely something that is worth working towards. I think we need to work towards a relapse protocol. We've talked about this a ton in leukemia. When you relapse with ALL, there is a standard protocol from COG that has a 50% cure rate. Relapse leukemia is curable, like better than a neuroblastoma. I mean, it's just, and that's because your patients aren't doing a phase 2 study till they progress, and then another study till they progress, and then another drug till you progress. That's not going to cure anybody. We need to have patients go on, even if it's from study to study, but not till you progress, because then you're just doing, then your 4 relapses down. Whereas standard upfront therapy, what do? You do 5 cycles of 5 different chemotherapy agents, and then surgery, and then transplant, and then radiation, and antibodies, and retinol. Why don't we have a protocol like that for a child who relapses? Curative actually is a curative trial, and not just phase 2 to phase 2 to phase 2 to phase 2. And we talk about that a lot at the end of TRC. We don't have that in place yet, but that needs to exist. When we do cyclophosphamide, which is our choice, not everyone's choice for a first relapse. And then when we get kids either close to remission or as close as we're going to get, and then maybe they need something else in between, or if they're in remission, they can go to DFMO or DFMO Velcade and then struggle to DFMO, but something that starts them and really down till we get to remission, and then something for maintenance to keep that away. I think we need to work towards that in neuroblastoma. There is nothing like that.
Is it even possible? It seems like
Oh, yeah.
neuroblastoma, every kid is different.
Yeah, that's true.
You know what I
Not
mean?
every child will make it through.
Exactly. What we did, and one of the other parents did, same thing, didn't work for us. So it's like, how can you have a certain set of rules?
Well, I think that's what's exciting about the
Molecular guided.
molecular therapy.
Which is why I love biopsy and relapse.
Right.
We need to understand our kids to know which group maybe that they should go into, which path they should follow. We clearly have so much work to do, but
One of my friends' kids had leukemia, and one of the things with them, and I might be wrong, but I felt like every step of the way, depending on how his cancer reacted to this drug, it changed, but he's still on COG. Like, it's like, okay, now we give him this, and then if he reacts this way, he gets this. If he reacts this way, it was like a umbrella thing. What is neuroblastoma is not like that,
No.
right? It's like, is that why we're not where that is? Is that a better? Should we be looking closer at, like, this kid reacted this way, so now they get this? And
So that's been attempted to look at, and some of it is, segregated based on risk groups. So to some degree, that has been done, but it's not the site of neuroblastoma that we're talking about now. So, changes that have been made in my very young career has been, that now, if you have a small adrenal mass and you're an infant, we observe it. We don't even remove it. And so, based on age and DNA ploidy and in-mix status, kids are treated differently. So there is that similar kind of branching as far as treatment. As far as being on study and response to therapy, like if you're on an upfront therapy, I do think if it looks like you haven't responded at all to Cytoxan, topotecan, don't use those agents again. So sometimes staying on a study and following study may not be the best thing, and you may need to be, innovative. But I think some of that we are learning and are continuing to try to learn. In every patient that goes on a COG trial, some of that tumor is contributed to biology studies, which hopefully we'll continue to learn from. And then on the molecular guided therapy, we're trying very hard to learn from every one of those tumors. Will that be in a timely enough way? If you're relapsed when you go on to molecular guided, I don't know. There's definite progress. When I started my residency, so I was an intern in 1987, and the first patient, that I had boundary issues with and adored was Noah, and he had stage 4 neuroblastoma. And at the time I knew he had a 12% chance of survival. And I really thought he ought to be the one in that 12%, And so, we have seen progress in the last 25 years. Not enough.
the changes in leukemia happened over 40 years of really intensive research that has gone into that. In neuroblastoma, we've seen a lot of intensive research in the last 10 years. So I think hopefully we're going to get to that. We are starting a program here at Helen Voss where patients will be biopsy at diagnosis, and any time, when they're having their surgery, every time that they're having a biopsy done, a portion is going to be profiled, and which will hopefully help us to get to that point of understanding.
A larger database of
Right. And upfront, can we, in other projects we talked about in the MTRC a lot is can we do the molecular profiling, have upfront diagnosis and look for those gene mutations that could potentially add a targeted therapy to upfront therapy to really try and. So upfront therapy would be different for every child because it depends. It would be the standard upfront therapy with a targeted agent added in addition. And I think that that's something that is feasible in the next year if we wanted to do a pilot of that and start to really
with upfront therapy.
Upfront.
So you do believe that that will occur?
that we would like to see that occur.
Okay. And what steps need to happen in order to make that change? Yes.
So it would be a pilot. It wouldn't. Yeah. So it would happen through the NMTRC as a pilot study. It's one of our goals.
So if they actually end up funding through CAUSE Project every child and they collect biopsy tissue from every child at diagnosis, will that data then be readily available to anyone?
COG data is not readily available.
But currently, all kids that go on a COG trial have tumor submitted, and it does get studied. But probably, currently not in a time that changes the therapy for that child on neuroblastoma. In Wilms tumor, data from loss of heterozygosity, so molecular data, changes our treatment currently. So we get that back in time to add a drug if needed. So I think we're on this continuum of improving molecular knowledge that's going to make therapy for neuroblastoma better. I really have tremendous hope that it's going to be good.
What I find very strange to try and comprehend, and I think you're probably thinking the exact same sitting there as well, being from the UK. We only have had a relapsed neuroblastoma option in the last few months in Europe, not just in Little Ireland, in the whole of Europe. The Beacon trial, which is the irinotecan and tema, and that's only been the last few months. And when you were talking about not being able to get enough children onto study to make studies viable and to not have enough children for data, surely it would make much more sense if Europe and America were working together. If I took your table and placed you into a European hospital, they would think we're insane. I'm sitting here sometimes thinking, am I on an alien planet? Because, and in Ireland, which is the only one I can speak for, there is a relapse program for every other cancer. Even medulloblastoma, there's been a relapse option for that for years, and we were told nothing. And in fact, even one of my friends who is on that relapse program has "not for cure" written on the top of her notes. Not for cure. And yet, I'm only a few hours away, and yet we don't have enough data. And one thing that is so limiting is the lack of data and the lack of amount of people to get on these trials. But what's so limiting for us in Europe is to get on one of these trials costs more than $500,000. So no person can ever afford to do more than one, and very few people can even afford one. But it's such a shame. The DFMO study could be filled in a week. It's such a shame. And I know you can't answer those questions. It's the people in Europe who need to answer those questions.
The DSMO trial, I have a little bit of, I'm extraordinarily enthusiastic about putting kids on that trial at the end of standard therapy, trying to prevent relapse. But I'm also sensitive to your other families from Ireland who can't do that. Or I have families in Michigan who believe they can't do that. That means driving here every month, which may seem like a small thing to me, but I've presented that study to families who said, oh no, we can't do that. And what I have to be honest about is, I don't know that that's going to help them. I don't have a crystal ball to say that is going to make a difference. We place our hope in these things, and I would admit I have hope in that. But I know that those families that can't do that we're really withholding something that has promise. I don't know.
We won't know for until the study is completed.
But it's
And
more
really
not the
very
DFMO,
personal.
it's more the relapse. The relapse,
Yes,
you know, the
yes.
fact that you've got varying different hospitals with varying different options, and you know,
No
and
agreement.
the other half of the world don't. You know,
Even here between hospitals, there's no, the agreement's just not there yet. And